Hi, the following content is for educational purposes only and does not constitute medical advice. If you are a healthcare provider, please consult with your affiliated institution or local ethics committee for ethical guidance related to clinical practice.
This is module 21 in BioE 131. There you go. Take it away, David.
Okay, I think the last thing we wanted to talk about were some of the implementation issues, ethical issues in implementation of AI. And we're going to talk about a few different issues. The way in which it may be not understood well and cause problems, unintended consequences of uses of AI, and then lastly, and more broadly, the way in which I think AI is part of something broader that represents a challenge to the ethos of medicine. So this is going to be the more abstract part of the talk at the end. So what did I mean by misuse of algorithms? I think that all of the people who are, all the data scientists I know who work on this are all acutely aware of data limitations in the work that they do. Some of them, though not all, are aware of value decisions that are embedded in the design choices that get made in building algorithms and models. Um, uh, um, and they also are usually acutely aware that the results of an algorithm or model may not apply to individuals and populations where there just isn't as good data and it can't be applied to. The problem is that while data scientists may be aware of this, in general, clinicians and health system administrators may not be. And the fact that this is such a black box and that most physicians don't know very much about AI may lead to, we know that it leads to over valorization and over reification of the results of AI. Hey, there's huge amounts of data. It's showing us all these things. So not always, and there are definitely skeptics among physicians, but sometimes it can lead to situations where the algorithms and models are being used to do more than they were really designed to do, or used in ways that they were really not appropriate to be used as. Just to give you an example of the reification problem, there are lots of them, and in fact, a colleague who we've been working with, we're going to try and do a clinical trial to see. There's definitely been areas where clinicians have lost clinical skills as a result of reliance on the numbers they get from an AI, and that's sometimes problematic because it may be that the clinicians were better before that. But I'll just give you one trivial example that I think really illustrates this point very, very wonderfully. So the idea for this particular algorithm was thinking about the fact that when radiologists who are looking for tumors are looking at radiological images to find tumors, they have to look through dozens and dozens, maybe even as many as 100 images in order to be able to find one image that has tumor in it. They're pretty good at it. They go reasonably quickly to do that, but it takes a lot of time to go through every image and make sure they don't miss tumor in one of the images. So the thought was, this is exactly the kind of thing that they could train AI to do reasonably well. Now, the most important value, and this is again the way values get embedded in design, the most important value for any kind of machine learning to try and take on to help in this process is that it have an absolute zero, or as close as you can get to absolute zero, false negative rate. That is, it has to have very close to 100% sensitivity. You would never want the algorithm to miss a tumor, so if it's going to help. But then if you set that at absolute zero, you could tolerate a high degree, not as much specificity, and you could tolerate a high level of false positives, because if you ran 100 images that have one actual tumor in it, as long as that one tumor is in there, even if it has 40 false positives, it's still going to save a huge amount of time because the radiologists only have to look at 40 images instead of 100 images. So here was this tool that seemed like it was going to be great. It was going to reduce the time significantly by reducing the number of images that radiologists have to look at, except it didn't work. It turned out it took longer. Now, why would it take longer for radiologists to review 40 images than would it take them to review 100 images? Because they knew that the AI saw something in all of those 40 images to make it say that this was positive. the radiologist took much longer looking at each image just to make sure, trying to figure out why did it think there was tumor here. And the result was that they took so much longer on each image, it wound up taking longer than what they were doing before when they were doing the full 100 images. So this tool that seemed like it was very well designed to wind up producing time saving for radiologists. It seems like the perfect thing. It wasn't replacing physicians. It wasn't replacing their judgment. It was really a great tool to just reduce the amount of effort that was needed by clinicians. But that reification of the results from AI caused them to doubt themselves whenever they didn't agree with the AI, which made something that was designed to be to be faster take a lot longer. And
Was it
again,
true? I'm writing this, but I want to make sure it's true. But so there was no overall benefit in their diagnostic performance.
correct.
They took longer to look at the 40 because they were basically petrified they were missing something, and the actual outcomes for the patients were not improved. So it was just a
Correct.
loss. It was an unmitigated
Correct.
loss because you're getting exactly the same performance, but you're spending more time.
Correct. But there's a solution to this, and this goes back to the issue we were talking about before about the way in which this is black boxed. If the if the radiologists who were doing this understood that they were setting the sensitivity to 100% and therefore tolerating a high level of false positives, maybe they wouldn't reify it so much, and maybe it would have been a solution. But because all they really know is the AI is telling them something and they don't really understand enough about its design, it wound up becoming something that was not productive. And in a way, I don't know if this is true, but it would be an interesting test to see whether or not educating radiologists about the workings of it would have turned that number around and made it so that it was actually very useful. And there's little trials that are starting to go on to try and see whether or not these reification issues wind up leading to better and worse outcomes in
Yeah,
practice.
it's very interesting to me because I can guarantee you that the radiologists were thinking the whole time, this is going to be a lawsuit. They were imagining the lawyer saying, but Dr. Jones, the AI said there was a tumor
Yes.
here and
Yes.
you missed it. And they're just imagining that. And because of that, I'm sure they're scrutinizing it extra carefully because
Right.
they've been given this flag, and the human brain, when given this kind of flag, so it's going to be very hard to change that behavior, would be my prediction.
Yeah, you could be right, and it'll be interesting to see what happens. But I think there's a lot of testing to see that when it comes from the design part to the actual implementation, there's a tendency for things to sometimes not work out the way we think they do. You know, if you design an algorithm that you've been very careful to make sure it's not biased against minority populations, but then when the clinician comes along, anytime he's got a patient from Atherton, he ignores the algorithm. And when he's got patients from East Palo Alto, he listens to it. You could have all kinds of inequalities exasperated in the implementation end, because when clinicians actually use these things, it's going to be quite heterogeneous. And we really need to study this.
Yeah, that's good.
I want to end with one last really big point, which has to do with the ethos of medicine. When you think about most ethics, most of medical ethics, a lot of what I cover in my Bio class, for example, and a little bit of what we've covered in this class at the very beginning, it's really based on an assumption of a fundamentally dyadic relationship between a physician and a patient. Importance of informed consent, confidentiality, all of these key concepts are really resting on a dyadic relationship between a physician and patient. And in a way, this goes back to the Hippocratic tradition, which explicitly is built on that. And then more recently, there are a number of bioethicists, I'm thinking here especially of Ed Pellegrino, David Tomasma, where they've really been explicit that this is the core of medical ethics, is that relationship between a patient and a physician. But the reality is, and AI makes this plain, like where does the AI machine learning that's making these recommendations, which may be binding or may not be binding, but may be having an influence, and in some cases, the health system may have said, no, for this issue, for good reason, we think the AI should trump. In all those things, where does that fit in that patient-physician relationship? And I think this highlights the reality that for most people, the myth of the dyadic relationship is just that, a myth. And that really what we have are populations of patients who are being treated as a community by a health system. And there are, in fact, a lot of ways in which physicians' autonomy to act is quite limited. We have pharmacy and therapeutics committees that make decisions about what's on the formulary and therefore what sorts of things physicians can order. We have pathways which are meant to essentially tell physicians what to do under different circumstances. And now AI is likely to exacerbate that and expand that so that physicians are limited in what sorts of things that they do. And I would argue that this means we need to reframe and rethink our whole ethos of medicine about what does it mean when we have a community of patients and a health system where they're being cared. And this is where I want to go back to the concept that I brought up in an earlier video of the learning health system and the learning health system framework, which can be built on the scaffolding of our existing ethic to some extent, but it requires some additions to it. And so some of this is a reworking of some work that Nancy Cass and Ruth Faden and some other folks, mostly at Johns Hopkins, have done about the ethics of the learning health system. So we talked about in the Belmont report the notion of respect for persons. In the learning healthcare system, this is captured by respecting the rights and dignity of patients and a commitment that in a learning health system that ought to be an important part of what we do. Beneficence, which included both beneficence and non-maleficence, this is captured in the learning health system in three ways: the obligation to provide optimal care for each patient, the duty to avoid imposing non-clinical risks and burdens, and the obligation to improve clinical care through learning. And so this way of cashing out those other obligations and duties says that that learning is actually an obligation and a duty of the health system that we have towards patients. Considerations of justice is captured by the duty to adjust and reduce unjust inequalities. So that's something that we could use data and learn to do, and we have an obligation to do that to address and reduce inequalities. And then we have an obligation to respect clinician judgment. But in addition, and this is the most important addition to the learning health system, patients have obligations and duties too. They have a duty to contribute knowledge when there is little risk or effort involved. And so their data becomes something, the byproduct of their clinical care can be something that can help us improve care for other patients and help potentially reduce disparities so that they pass on the benefits that they themselves have received from contributions to others. That is very contrary to the ethos of medicine. A very famous philosopher, ethicist named Hans Jonas had argued that there is absolutely no duty for anybody to be involved in research except under the most dire circumstances. But I think the current health situation that we're facing with COVID highlights the way in which we're all connected and the way in which we can all learn to benefit everybody, and that in a way we're all in this together. So I'm hoping that that communal set of values is something that can come out and be recognized. Now, for this to be validated, Faden and Cass and others have pointed out that we need to make sure that this is done in an appropriate manner, and this includes at least 3 ethical requirements: active engagement with patients about ongoing learning activities so that patients have the expectation that learning is a part of what happens in health systems, transparency about the type of learning that takes place, and especially and above all, accountability in translating the results to improve patient care. Just using this data to get a new grant or to get some publications is not what this is about. It should be about learning from patients so that we can improve care for other patients. And that's really what's required in the new learning health system. And that's it for this
One
module.
quick question is there a difference in the European conception of this new model versus the US? I'm asking because I've heard more Europeans talk about their duty to commit back than I've heard Americans, but I don't know if that's anecdotal or a real thing.
I think that there are certainly more communal values in some other countries, and the idea of the collective obligations that people have than in the US in other countries, but it hasn't necessarily cashed itself out in the actual ethos of medicine. In fact, in some ways, the opposite. Things like the GDPR in Europe, so some of the privacy protections that have been put in place have really gone back to that older vision of we have to make sure that everybody consents to everything, and really harkening back to actually not individual rather than communal values. So there's a little bit of a lack of fit about the fact that there are more communal recognition of communal obligations, but that may not fit with some of the regulatory requirements that have been put in place.
Very good. That's the end of the module. Thanks very much. Signing out.